Good afternoon. We are back at 3 p.m. for Bariatric Friday. My name is Kemal Erkan. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. I'm doing great. As usual, as I tell you before, I could be better. There's some more news from Tigray, unfortunately.
Yeah, so the interesting thing for today is our topic is life expectancy. So,
yes.
And how bariatric surgery improves life expectancy. However, and one of our challenges always is how are we able to really separate ourselves from real world issues. And in the earlier session, we did discuss a little bit about what's happening globally. Now, I wanted to kind of ask you, since the last time we discussed the Tigray issue, if you have any new updates from Tigray.
Yes, the update is the same, essentially, Kemal. Here you have the biggest humanitarian crisis in the world, probably the largest conflict in the world, despite Ukraine considering the victim numbers, and that is the conflict that's going on in Tigray in northern Ethiopia. And, the siege of Tigray continues. That area has been totally and completely blocked from the outside world because there is no electricity, there's no telecommunication, there is no internet. They don't have food. The main hospital in Mekelle, say today that they have run out of insulin. And the Ethiopian government, which is led by the Nobel Prize winner, premier, instead of sending medications, is continuing to bomb cities. Today there was another drone attack on the city of Mekelle with civilian deaths. And the tragedy of this, Kemal, is that I am forced to talk about it in a session where we are about to talk about bariatric surgery to show you my frustration with this. This is something that is very difficult to sleep when you hear things like that. The problem is, of course, you turn on CNN, you turn on PBS, you turn on Fox News, and there's no word about this. That is the biggest tragedy we have. You have all the heads of states of the world gathering at the UN for the General Assembly, right now in New York, Kemal, and Tigray is not in the agenda. The biggest humanitarian crisis, the largest conflict in the world is totally forgotten. And this is the conflict in Tigray in northern Ethiopia. So again, I apologize for intruding this in our session, but I just wanted to...
again, Dr. Irgau, so you have your patients, they see you, they know your background, they know the issues you may be going through, what's bothering you. So these are difficult to separate. So when something happens in Turkey, my entire family is there. So that's affecting what's happening here, what I do here. But this Tigray issue is, I was earlier talking to Anthony in our UMACO session, and it seems like Tigray maybe was the start, and now every other region is following that. So now we have trouble in every other part of the world. And I was actually giving a heads up for people to be prepared for winter. And there's this, well, I won't go there, but it's going to be a different winter. But it's been a different winter for the last 3 years for people in Tigray.
Absolutely, absolutely, Kemal. It's been 100 years now since the first dose of insulin was given in the world, right? And that since then we have decided that people will not die of lack of insulin everywhere in the world. Insulin is available, one of the most important drugs, because people who need it will die within days if they don't get it, right? Tigray right now is running out of insulin. There is no way of getting insulin. If I have a relative with diabetes who requires insulin, Kemal, I cannot get it to them because the only way into Tigray is through Addis Ababa, the capital of Ethiopia. And I cannot do that because the Ethiopian government is the one that is putting Tigray under siege. And the reason they're doing this is because they want to break the will of those people by starving them and by denying medication. It is atrocious. It's a humanitarian crisis of greatest proportions in this day and age. And yet the world, the West, They're not even talking about it. And that's
one question: is there like a public site that people who want to donate?
Absolutely, absolutely. You and I have set up, obviously, Friends of Tigray in Delaware. That's one. But the Tigray Development Association is one charity that is actually active in the United States, and they have GoFund initiatives where people can give. But the tragic here, Kemal, is that even if you and I have money right now, how are we going to get it to these people, right? I mean, we have seen situations like that, like the conflict in Syria, in other places, where the United States actually dropped food to people who don't get it, right? They're not doing that in Tigray. It's not happening. So so the greatest thing we could do right now, thank you for that, is to really raise awareness so people can talk to their representatives, can talk to their congressmen, senators, and tell them, hey, you're telling us so much about Ukraine. Okay, we appreciate that. But how about Tigray? How about the 6 million people of Tigray who have been under siege for 2 years now? How about them? That's what I would like people to ask. And I appreciate again, Kemal, for giving me the opportunity to talk about this.
So this website that I'm sharing right now on the screen, Dr. Erkan, is that the right one?
Absolutely, absolutely. Yeah.
So, all right. So I just want to make sure that there will be people who are willing to help, and we want to make sure that they can access, and hopefully we can do better and we can do more. And the war needs to stop. So
it needs to, absolutely. Thank you again.
My pleasure. So let's go back to our Bariatric Friday. And so let's get the other party in. Right here is our 3 patients. I think I really do these with images, don't you think?
Absolutely, absolutely. So we have Karen, Denise, and Patrick, right, going through the process for us. And this.
So you remember the names better than I do.
I do.
Well, because they're your patients, right?
It's part of my job, right, to remember names, Kemal, and I'm blessed to be able to do that.
So, Dr. Irgau, we try to cover different topics. Patient who may be morbidly obese, who are going through these problems, these process, getting the surgery, not getting the surgery. But I'll tell you something very interesting before we start. So then maybe, I mean, if you don't want to talk about it, you can tell me. But I want to talk about it. It bothered me so much last night. I was checking one of the patient surveys. Okay. So this is from the primary care side. Mm-hmm. As you know, when we are sending, when we send every visit, like they may have like 2 visits this month, like past month. So this month they will get a survey request. So I improved that message instead of just sending like a simple survey message. In the same message, this is in our EMR, in our power chart. Mm-hmm. In the same message, I put our ACO, Accountable Care Organization programs. Mm-hmm. And bariatric is one of them, diabetes, behavioral health, the hospital follow-ups. There are a couple others, I can't remember all of them right now, but first I thought patient was upset because maybe we were doing case management and then we sent some specific emails. Mm-hmm. But this patient, BMI 52, was upset and offended because we were trying to use the AI algorithm to target her. Now, I know you don't like when I kind of put you on the spot with these, but this bothered me so much and I couldn't wait until tonight to talk about this. But the other thing is that it bothered me, like how real this stigma is. So patient was upset and they said they will never refer to us to another friend for the PCP services, although they have seen after. But they were upset enough to fill out a really angry survey result. Like this is a big issue. This is bigger than what I think it is. On one hand, I believe that we are trying to, that we are doing our best, because we tell our providers, now this is on the non-bariatric side, I tell our primary care, look, patient with certain BMI level, they shouldn't be leaving your exam room without a proper assessment and plan of morbid obesity, right? And then all of a sudden I saw this survey, and you can say, well, come on, it's only one survey, but it's one is enough to kind of, well, actually there was another one similar to that, but they were, they just didn't want to receive any survey. So we really need to kind of address this issue in a way that I was going to call the patient after our meeting last night with all providers. I didn't, because I didn't want to ruin my night. But I do want to call that patient at some point. And we are talking about life expectancy today. And as I'm thinking that I'm helping this patient saying that, no, you don't even go there. We can't talk about it. I'm not morbidly obese. So that's your metrics that you think that I am. Well, BMI 52. So.
Absolutely. Actually, Kemal, this goes to the heart of the issue that we're going to discuss today. We are going to discuss today that bariatric surgery has been proven to extend life expectancy. In other words, people who have morbid obesity, if they undergo bariatric surgery, they are likely to live a lot longer than people who didn't have bariatric surgery, right? Now, why do we need to say this? Because right now, only 1% of those who are eligible for bariatric surgery are seeking bariatric surgery. And the question that follows that is, why only 1%? And that goes to this issue that people are not seeing morbid obesity as a life-threatening condition. Many people look at morbid obesity as a problem of appearance, right? There is not an understanding that it's an illness. I bet you, Kemal, if you had sent a survey to this specific patient saying, hey, we see that you are over the age of 50 and you have a history of colon cancer in your family. We think you should have colonoscopy because you're at risk for colon cancer. What would the answer have been from this patient? They would have said, thank you for reminding me of this because I don't want to have cancer, right? Because cancer is a disease in their mind. But in their mind, morbid obesity is not. In fact, pointing out to somebody that they are morbidly obese is offensive to some people. Why? Because we have this stigma in our head that it's a question of appearance, right? So it is, people look at it from a political correctness point of view, right? Instead of looking at it as a disease. This is actually precisely why up to very recently, many doctors shied away from discussing weight at a visit, right? Because somehow they felt they were going to offend the patients instead of thinking they're educating them and helping them, right? So the answer that you got from this patient explains the problem that we're running against. And also it justifies even more than ever why the sessions that we're doing right now are so critically important, Kemal. I mean, somebody was telling us yesterday, right, that our sessions now have a very, very good visibility. And I'm very happy with that. Not because I want to become famous, Kemal. It's because I want to put obesity center stage in a society where obesity is the leading cause of disease. Because as we will speak shortly, obesity is related to the most prevalent causes of death in our country. What are the leading causes of death in the United States, Kemal? Number 1, heart disease. Number 2, cancer. Number 4, stroke. Number 7, diabetes. All these conditions are directly related to obesity, right? Cardiovascular disease, stroke, diabetes. So your life is being shortened because obesity is causing the diseases that cause mortality early. Mm-hmm. If this is not important in our health system, what else is important? Come on.
So, we work on these images. Sean helped me with some of them. I call them evil sisters, nothing against the sisters. But, hypertension, COPD, diabetes, kidney, heart failure. So we're going to actually use these images later on with our ACO programs. But the reason I needed to do this, to explain people, look, this is a disease that's causing all the other disease altogether. So it's not just a disease by itself. So the reason obesity is not there is because this is built on obesity. So this is either it can initiate these, it can trigger them, or it can make them worse, right? So,
absolutely.
But even with that, people, what's 52 BMI, Dr. Erkan? So for an average female, 52 BMI, what's the weight? Like 350?
So, absolutely. So if somebody is about, let's say they are about 5'5" in height, right? Mm-hmm. Their weight is going to be close to 350, right? For them to have a BMI of 55, mm-hmm. right? Approximately. So that is a lot of weight. That is a lot of weight. And if somebody is not aware that that weight is really weighing on their health as well, there is a problem, right? But on the other hand, because of the stigma that we associate with obesity, and the key stigma here, Kemal, is that we associate obesity with weakness of that person to deal with it, because we think obesity has something to do with willpower, right? And there is nothing further, from the truth than that, Kemal, and that is we all know that except for a small minority of people, losing weight, especially as we advance in age, is the hardest thing anybody can do, right? People go on a diet for days and days and days and days, and they struggle, and then they manage to shed about 8 to 10 pounds, and then they stop that diet one weekend, that 10 pound is up, and the next week it's going to be 12 pounds up. And that's what people struggle with. So it's not really a question of willpower, it's a question of biology. Our body essentially has been engineered to prefer a higher weight, because for the vast majority of our existence, we had not enough food. So conserving food as long as possible is part of our genetic makeup. That's who we are. And when we live in a society where there is plentiful of food, then obesity comes up, right? I mean, it's so counterintuitive, Kemal, for somebody to have so much weight on them, to be so much fat in them, so high their weight, and yet they are constantly hungry. It doesn't make any sense, right? A mechanical system, you would think, would be utilizing the energy that it has inside before asking you to look for food. And yet, a person who is morbidly obese is hungry. Why? Because the biology drives everything. Right? Of course, there are other issues, lack of mobility, the fact that we associate food with pleasure and with social activities, all those cultural things also are affecting us. But the basic tenet remains that our biology drives us into becoming more obese. And from our point of view as health workers, we have to look at this as a health threat, because the result of obesity are the diseases you mentioned: hypertension, stroke, diabetes, cancers. It makes no sense for us to treat them one by one and see people die early or have a horrible old age because of the ravages of these diseases, right? And currently, morbid obesity, we define it as a body mass index greater than 40, right? And the most effective treatment we have is bariatric surgery, right?
So, as I'm listening, another patient example that, I have a patient, again, on the high 40s with the BMI, and they have joint pain, and they have hip pain, and they're trying to address the hip pain with an orthopedic surgeon. Well, the reason is because you have 150 extra pounds on those joints. That's why you have hip pain or joint pain, right? So this, when we talk about life expectancy and how bariatric surgery is extending this, is because this is the main core, like the main origin of the problem. Someone may have, if you play tennis 5 times a week, like probably Roger Federer right now is having a lot of pain with different parts of his body. He's not going to need bariatric surgery because his pain is not coming from
weight,
having this extra excess weight. But if he was 200 pounds heavier, then our first thing that we have, and if he wasn't playing tennis, then we would say, okay, well, this is what it is. So this is why you have this pain. And this, how you're going to get rid of it is not by getting a surgery, because surgery is not going to help you. If you get an orthopedic surgery, without addressing the weight issue, which many programs these days, they are actually sending their patients to us before their orthopedic surgery. So now the one that I'm still, maybe I asked this before, but so my learning is a little bit slow these days. So cancer and the bariatric surgery, like, can we just address that again, just so
Absolutely.
that how that's helping?
Absolutely. So to just give a little bit of a broader view first, Kemal, since Dr. Poirier, who is one of the early bariatric surgeons in this country, who was a professor in the University of North Carolina, he published a very, very important article in 1995. The title of the article was, "Who would have thought it? One simple operation leads to complete cure of type 2 diabetes," right? Since that paper came out, we understood that bariatric surgery was not just about getting people to lose weight and live a comfortable life, but about really helping them with their health, right? And then as we saw more and more data, we could see that with bariatric surgery, not only people were losing weight, but becoming healthier by having less high blood pressure, less stroke, less cardiovascular diseases, and now more and more we're understanding cancer as well. So intuitively, we knew that by getting rid of those diseases, people were living longer. And then we saw studies. There was a study that was published in 2020 in the New England Journal of Medicine, which was the study done in Sweden. It was called the Swedish Obesity Subject Study. And what they've done, Kemal, is that from 1987, they followed up 2,000 patients who were morbidly obese who underwent bariatric surgery, and about 2,000 patients who were morbidly obese but did not undergo bariatric surgery. And they followed them up. And then on average, they were able to demonstrate that the ones who did have bariatric surgery lived longer. In other words, there was excess mortality among the ones who did not have bariatric surgery. So there was data clearly showing us that what we knew was absolutely true. Now, going back to the cancer issue, Kemal, more and more studies now, they are showing that many cancers, up to 13 types of cancers, are actually related to obesity. This includes things like cancer of the ovaries, cancer of the uterus, cancer of the breast, colorectal cancer, which is cancer of the colon and cancer of the rectum, cancer of the pancreas, cancer of the stomach, cancer of the esophagus, which is the food pipe, right? A cancer known as multiple myeloma, right? Cancer of the thyroid, cancer of the kidneys, something called meningioma, which is a cancer that affects the lining of the brain and the central nervous system. These are many cancers that are related directly to obesity, which means that if your BMI is within the morbid obesity range, you're more likely to have these cancers. And these are not nice or gentle cancers, Kemal. These are life-threatening cancers, right? So not only now we know that obesity is a metabolic disease, meaning that it gives us those derangements that lead to cardiovascular disease, to hypertension, to stroke, to diabetes, but it is also a carcinogenic disease, which means that it is a substrate for cancer to grow in many organs of our body. So accumulation of fat in our body in excess, Kemal, is not a nice thing at all. It's not a good thing, not only because it's a burden to our daily living, not only because we cannot walk, we cannot run, we cannot sit in normal chairs, we cannot tie our shoes well, we cannot take care of our body well, but because it's creating those disease, right? And now we're saying we have bariatric surgery, which is an effective treatment, right? And we are saying this because very few of the patients who are actually eligible for this treatment are coming forward, Kemal. And it's important that
it's 1%, right?
Yes, 1%. I mean, if you told somebody that you were going to give them a passport to a country where they are likely to live 5-10 years extra from where everybody lives, don't you think everybody would emigrate into that country in a heartbeat, Kemal? They would, right? That's human nature, wanting to live.
Yeah.
Right? So that's what bariatric surgery is, a passport to a longer life for people who are suffering from morbid obesity.
Well, longer life, but also better quality life, right? So it's not just life being
Great
longer.
point. Great point. Great point.
So because we want to have we don't want to be bedbound and then not to be able to do anything and live for 10 more years, but we want to actually have a healthy life, longer healthy life.
Absolutely.
So this does help us to spend better time with our families, friends, and whatever we are doing, it's better. So now the impact on different diseases, I think the awareness of it is now getting better, Dr. Erkan.
Yeah.
What I see with many of the progress notes these days from the other case conference that I do, I see that the providers are also including, they actually, in many cases, I see them starting with the bariatric, the morbid obesity diagnosis. And that's why we got a couple patients upset with that. Even they are not, like right now, we also ask them, so here's the situation. So I guess why it's important. One is clinically, we know it's important. We already addressed those in so many different ways. But from the medical responsibility and liability standpoint, when I don't take care of that issue, and if something happens to the patient, and then who's left behind is going to be asking these questions. Why did you not send my sister to a bariatric surgeon? Did she, like, I don't have this in her chart. So because of that, we have this form that patient needs to sign saying that I refuse this. It gets to that point, like I refuse to receive this consult. And I have some patients sign those, and I saw them, and I'm like, what are they thinking? What are they doing to themselves? Maybe their loved ones, do they even know about this signature that they refuse the help from their healthcare providers? So when we are talking about the benefits of this surgery and how it's giving them more potentially longer life, if that's not given, how are we going to actually answer those questions? Is another patient also needs to ask themselves, like, this is not just their decision, but they need to talk to their loved ones and then say, yes, I will be living with the 375 pounds for the rest of my life, and then I may not make it. So, I mean, I always go back to, my parents at one of these sessions. Usually, my dad is 81 years old, and I don't want him to, we are not ready to lose him at age 81, because he's healthy, he's doing well, his activities are fine. So if he's able to live for another 10 years with this quality, wouldn't that be great? Right?
But Kemal, take your dad, Mr. Erkan, right? What is so clear about him? He's lean, Kemal. He does not have morbid obesity, right? And another thing that we know intuitively that morbid obesity really decreases life expectancy is that you don't see very many people at your dad's age, at Mr. Erkan's age, who are morbidly obese, Kemal, because he just doesn't forget. There are too many things against you when you have morbid obesity, right? I mean, you showed me a picture of him doing kayaking, right? Not too long ago, right? It wouldn't come out, right? Well, physically, he would not be able to do that unless he was as lean as he is, right? So that is what we're saying also, is that it is important, as you said, to take care of morbid obesity, not only because it is going to be shortening life expectancy, but also even if you live longer, the quality of life is going to be terrible, because you're always going to be after medication and after doctors, and your mobility is going to be limited as well.
No, that's good, Dr. So anything we want to add or cover? Like, I don't know if we address, I think we addressed most of them.
Yeah, we did, Kemal. I mean, it is clear right now. It is clear that, we are saying to people to take care of themselves, not by saying, oh, you have to do it all yourself. Because once you get to that level of obesity, it's very difficult, Kemal, right? And what we're saying is there is a treatment that is available right now. And this treatment has been made as safe as it's ever been, right? We talk about gastric sleeve and gastric bypass as procedures who have a safety profile now, which is comparable to things like gallbladder surgery, to hernia surgery or hysterectomy, right? Very high levels of safety, right? So with that in place right now, it's important that people explore this. Obviously, bariatric surgery has not reached a stage where it is prescribed, right? We're not saying you must have it. We're saying consider it, be aware of it, don't suffer in silence, explore those options as well.
So after this session, I'm going to call that patient.
Okay.
Or maybe I'll send a link.
And you can quote me on that.
So I really want them to take this seriously. That's part of the problem that we are having, Dr. Erkan. So when I see someone not taking advantage of if I'm refusing some help that's given to me at no extra cost to make my life better, I would question my judgment system to say, like, why do I do that? Right. So this is why it's we are talking about this, and we will be talking about it. We want people to have a long, healthy life, longer healthy life, and then hopefully we can impact more people's lives in a good way. Well, Dr. Erkan, thank you so much for joining us.
Thank you. Thank you.
Off next week, right?
Yes. Yeah.
And the following week, I believe, right? So the 2 weeks we are out for Bariatric Friday, but with the UMACO updates, we will be back next Friday. Again, thank you, and have a nice weekend. Bye-bye.
Okay.